In today's case study, I will be discussing patient CB, a 35-year-old Caucasian female who was born on February 12, 1981. She is a patient of Dr. Brian Marias as well as nurse practitioner Nancy Robb. Today, she is presenting with a sore throat, sinus pressure, and to review her antidepressant medication. She has no significant family history. She does, however, have medical history in previous diagnoses of anxiety disorder, mixed hyperlipidemia, methylfolate deficiency, vitamin D deficiency, and she has a body mass index of 25. Her vitals on today's visit present with a height of 61 and a weight of 135, giving the 25 BMI, a temperature of 98.6, pulse of 71 beats per minute, respiratory rate of 16 beats per minute, and a blood pressure of 121/80. The patient denies any surgical history as well as ever being a smoker. The patient's social history includes that she is single, she is employed by an operations recruiting firm, she is originally from South Africa, and reports only social alcohol use. That is liquor, typically 2 to 3 drinks a month. She reports 7 to 8 hours of sleep per night, as well as no tobacco or illegal drug use. The patient reports no known drug, food, or environmental allergies and is currently taking atorvastatin and calcium 20 milligrams by mouth daily for her cholesterol and hyperlipidemia, as well as vitamin D3 5,000 units daily by mouth for her vitamin D deficiency, escitalopram oxalate 5 milligrams daily by mouth for anxiety and depression, L-methylfolate 15 milligrams by mouth daily for L-methylfolate deficiency, and Lutera 1 tablet daily for her birth control. The patient reports being sexually active with 2 partners in the last year, but no signs and symptoms of sexually transmitted infections, as well as a negative pap smear in November 2015, since when she has had no new partners. Focusing on the present illness, the history of physical illness shows us that the patient has been complaining of a sore throat, cough, and sinus pressure, as well as pressure in the ears for the last 5 days, with little relief in taking sinus medicine such as Advil Cold and Sinus. She rates her sinus pressure and ear pain around a 5 out of 10. She denies any factors that increase or decrease the pain. She denies any current weight change or change in strength or exercise tolerance, as well as denying fatigue and lightheadedness. She denies syncope or fever. She does report having chills at night, but no night sweats, and no change in appetite. She denies headaches and denies any recent head injury. She denies any vision changes, blurred vision, double vision. She denies tearing and denies pain or dryness to the eye. She also denies any eye itching or redness. As far as her ears, she denies any change in hearing and any ringing in the ears. She denies vertigo or bleeding from the ears, but she does report a pressure in the ear and a pain in the ear. She denies any bleeding nose. She does report nasal congestion, nasal discharge that is clear, a postnasal drip, sinus pressure, excessive sneezing, and rhinorrhea. She denies any dental difficulties or any gingival bleeding. She does report a positive sore throat, but denies a hoarse voice or excessive snoring. She does report a stiffness in the neck, as well as some neck tenderness and pain, but denies any masses to the neck. She denies any lumps or tenderness to the breasts. She denies any chest pain or heart palpitations or racing heart. She denies any trouble breathing or wheezing. She does report a cough. She denies any abdominal pain, denies any nausea or vomiting. She denies any bowel or bladder changes. She denies any specific pain in the joints or bone pain. She denies any numbness or tingling to the extremities. She denies any muscle spasms or neurologic changes such as memory changes, concentration changes, or tremors. She denies any seizure history. She does report depressive symptoms as well as anxiety symptoms, but does not report any trouble sleeping or changes in thought such as suicidal ideations at this time. She has no rashes or open sores to her skin as well. Moving forward to the physical exam. Upon examination of the patient is afebrile. She does appear acutely ill at this time, however. She has bilateral retracted tympanic membranes with fluid behind the ears. She does have conjunctiva that are clear with no discharge from the eyes. However, her nasal mucosa is edematous. She has clear rhinorrhea. There is moderate airway obstruction due to the edema of the nasal mucosa. She does have sinus tenderness to palpation, as well as a mildly erythematous pharynx, but no exudates. Her neck is supple, with no lymphadenopathy noted. Her lungs are clear, with no rales, bronchi, or wheezes noted. She has a normal sinus rhythm, with no murmurs, rubs, or gallops heard. And her abdomen is soft and non-tender at this time. In this patient, there were no additional diagnostic or lab tests other than the physical examination and review of systems from the patient, making it a clinical diagnosis. Based off the pain upon palpation of the sinuses, as well as the patient's reported sinus pain, acute sinusitis is a differential diagnosis for this patient. In regards to the ears, due to the fluid and retraction of the tympanic membranes, acute serous otitis is a possible diagnosis for this patient. And finally, acute pharyngitis could also be a diagnosis for the patient, as well as cough. For the patient is reporting some throat pain as well as cough throughout the day. Upon assessment, the concluded diagnoses were acute serous otitis media of bilateral ears, as well as acute sinusitis. Greater than 20 minutes were spent with this patient face-to-face, with 50% of the time spent in counseling, as well as education of the plan of care. For this patient's plan, we educated the patient to continue to increase her fluids to remain hydrated, as well as increased rest. We educated the patient to use over-the-counter analgesics such as Tylenol and ibuprofen for any pain as needed every 4 to 6 hours. Saltwater gargles and ice chips to soothe the throat 3 times a day was educated to the patient, as well as for the patient to return to see us if the symptoms had not improved upon completion of the antibiotic given. In addition to the education, the patient was prescribed Augmentin 875 milligram tablet by mouth twice a day for 10 days, as well as educated to begin taking Mucinex maximum strength, which is 1,200 milligrams twice a day, so 2,400 milligrams daily. We instructed the patient to take this until the symptoms began to resolve, which typically takes the use of one over-the-counter box. At this time, there is no need for any consultation or referral. If for some reason the symptoms did not resolve and ear pain continued, an ENT could be considered. There is also no need for labs at this time. If, again, the infection continues, a CBC could be drawn to interpret white blood cells, as well as a possible culture of any sputum the patient is having. Finally, education on hand hygiene, as well as the consumption of vitamin C daily for prevention of future illnesses, was given to the patient at this time.
Looking at the research article, I found that sinus infections are one of the most common conditions in adults, affecting millions each year. Sinus infections are characterized by the cloudy or discolored sputum, nasal blockage, or clogging of the sinuses that results in facial pain and pressure. The patient can also experience fever, cough, fatigue, and alterations in smell or referred pain to the teeth or ears. The healthcare provider should distinguish between bacterial and viral sinusitis to determine if an antibiotic is needed. In order to do this, you want to monitor the symptoms. 10 days from the onset of symptoms would suggest that an antibiotic is needed if they're still having symptoms, whereas if there's no worsening or there is slight resolution over time, concluding in 10 days and it is viral, that patient would not get an antibiotic at that time. Diving further into characterizing the viral versus bacterial sinus infection, when we look at the viral infection, we're going to treat the patient to relieve symptoms, such as with use of pain relievers such as ibuprofen or Tylenol, nasal steroid sprays, as well as saline rinses that can be used with a bulb that squeezes into the sinuses, such as a neti pot, mixture of baking soda, salt, and water, which will clear the sinus passageways. Looking at the bacterial treatments, it's going to be similar. You're still going to treat to relieve symptoms with things such as a nasal steroid spray or saline rinses to clear the passageways of the sinuses. And you can also use pain relievers such as ibuprofen or Tylenol. But in addition to that, you're going to perform what we call watchful waiting, which will determine whether you need to use antibiotics or not. If the decision to treat acute bacterial sinus infection with an antibiotic is made, then you're going to give the patient amoxicillin, typically with clobulinate, and that's going to be Augmentin, for 5 to 10 days in order to make sure that the sinus infection is treated appropriately.
When looking at the practice guidelines for the treatment of sinusitis, we see that the clinicians are recommended to use analgesics as well as intranasal steroids and saline irrigation for symptomatic relief of the patient. We also see that clinicians should offer watchful waiting periods without antibiotics if they are unsure if it is acute bacterial sinusitis, which is the inflammation of the nasal passageways as well as the sinuses. If the patient is not believed to follow up appropriately, the provider can go ahead and prescribe antibiotics at the visit and educate the patient to start taking these antibiotics if the symptoms do not resolve in 7 days or if they begin to worsen. If the decision is made to treat with an antibiotic or do the watchful wait and after 7 days no symptomatic relief or improvement is made, and then the antibiotic is prescribed, the clinician should prescribe amoxicillin or Augmentin as the first line therapy for 5 to 10 days for most adults. Finally, when looking at the practice guidelines, once the patient is treated with amoxicillin or Augmentin, if the patient fails to improve with this initial management by 7 days after the diagnosis or worsens in that time period, clinicians should reassess to exclude other causes of the illness as well as assess the antibiotic given. Any complications that are had should be noted and assessed. And if the patient was initially managed with an antibiotic such as amoxicillin or Augmentin, the clinician should change the antibiotic due to possible resistance. When comparing these practice guidelines to the patient in the office, the treatment we followed pretty closely resembles the practice guidelines in that we advise the patient to perform saline irrigation as well as analgesics as needed and intranasal steroids as needed. The only differing component is that we went ahead and prescribed this patient Augmentin 875 BID. For her sinusitis, the patient had the facial pressure as well as the purulent sputum, so we did go ahead and prescribe that. In order to be an antibiotic steward, we could have, instead of prescribing Augmentin, inform the patient to monitor her symptoms for 7 days to see if there was any improvement or resolution, and at that time, if not, we could have then given the antibiotic as opposed to giving it from the start. Here I have listed my references regarding practice guidelines and treatments for sinusitis. If you have any questions, you can go to these sites, and that concludes my case study at this time.